patient once came to me who seemed to have experienced side effects to almost every medication he'd ever tried. The reactions ranged from headaches, blurry vision, shortness of breath, even unusual things like a change in the smell of his urine. And by the time we'd met, he'd almost given up on treatment altogether. He looked at me pleadingly and said, "Doc, I really don't think my body can tolerate any of these medications." And at first I did wonder, was he one of the few that was genuinely intolerant to all psychiatric medications? But after getting to know him, I learned something that completely changed how I approach OCD treatment. The really fascinating and illuminating part about his case isn't that he was experiencing these symptoms, because he was. It was the reason why. Because OCD doesn't just affect the way we think. It also affects the way we experience our bodies. And if that's true, it can completely change how we experience starting a new medication. So if you've ever started a new medication for whatever reason and wondered, is what I'm experiencing normal? Should I be feeling this? Is this a sign that I should stop? Or if you just have anxiety, OCD, or health anxiety, I think this will be a very illuminating video for you. And for those of you who are new to the channel, welcome. I'm Dr. Robert. I'm a board-certified psychiatrist. And I specialize in treating OCD and anxiety spectrum conditions. And of course, as always, these are just educational videos, not intended to replace medical advice. And if you are experiencing any mental health symptoms, please seek the care of a local mental health care provider. And also, all patient stories are greatly altered to protect patient identity. So first, let's jump into John's case. And the interesting thing is, a week before his first appointment, he sent me an email. And this wasn't too unusual. Patients would often send prior records, other relevant information before our first visit. But when I opened John's email, something really struck me. It was a spreadsheet, a massively long and extensive spreadsheet. And it seemed to list off almost every single psychiatric medication I'd ever heard of. And next to it were all the different side effects that arose as a result of it. At first glance, I remember thinking, this is unusual, and potentially this man is very sensitive to medications. Or something else might be happening here. One of the first things John said when he walked into my office a week later was this: "Doc, I'm sorry. I get I'm a difficult patient." I could tell he felt jaded by psychiatrists, and this was his kind of last-ditch effort to try to get help. That's not an uncommon sentiment in my practice. This is the case for many people who've had poor experiences in the past. I definitely felt for John, and as I got to learn more about his life on that first visit, I definitely understood the pain this was causing him. Just to give you a little background, he was a man in his 50s, an accountant, a very meticulous man, thoughtful, I could tell reserved, but very sharp. And as we chatted, he began to reveal what his OCD symptoms were like. He struggled with just right OCD, needing to do things over and over again in his home and his regular routines that could take up hours and hours of his day. And he had to do them until they felt just right. Otherwise, he was plagued by this intense unease or feeling like something bad would happen if he didn't go back and redo it until it felt just right. And he'd seen many psychiatrists beforehand, all to no success. He'd even been in therapy for many years. But when I heard about the kind of therapy he'd done, it was a lot of talk therapy. It was a lot of talking about his week, the frustrations he'd had, but no actual OCD-tailored therapy. And that was a key point. And then I started to ask about medications. And of course, I didn't go through the entire spreadsheet. We would have needed multiple sessions for that. But I did try to get a sense of what was his experience with medications like. What happened when he started a new medication? And this is what he told me, and it might resonate with some viewers. Every time he started a new medication, he was hopeful. He hoped it would at least do something, but was always also cautious because of his prior negative experiences. But sure enough, he would trust a psychiatrist enough to start a medication at a low dose, would be assured that it would go smoothly, but then it inevitably didn't. He'd experience blurred vision, headache, intense nausea, whatever else it might have been. And then the psychiatrist would respond in one or two ways. Either tell him, no, it's fine, just keep taking it, you'll be fine. Or, stop the medication, let's try something else. And neither of these approaches proved very useful for John. But first, let's stop here and talk about what's actually happening. Most people think that OCD only involves intrusive thoughts and compulsions. And to some degree, that is true. But there is one factor that's much less talked about and is very underappreciated. And that's how it affects people's attention, their focus. And it doesn't just change people's focus to the outside world, to the potential dangers, but also inwardly, towards one's experience of the body itself. Psychologists actually have a name for this. It's called interoception. And basically, it's just a fancy term meaning being aware of what's happening inside your body, your physical experience. So that includes things like your stomach rumbling, your heartbeat, your breath, the muscle twitching. And all of us experience this to some degree throughout the day, right? We feel our stomachs rumble when we're hungry. We feel a minor muscle twitch here and there. You can think of it like moving into a quiet old home and you become very hyper aware to the creaks on the floorboards, the furnace clicking, the pipes expanding, and everything sounds a little bit off, a little bit more scary. And OCD can do a similar thing. It can make people more attuned to their bodily sensations. And then that also gives the opportunity for anxiety to latch on. And this can be particularly true when trying something new, something potentially dangerous, like a medication. So one's attention can become suddenly locked in to, was that a skipped heartbeat? Now you're very anxious about that. You're monitoring more closely. Everything that feels like an off heartbeat triggers more anxiety. And so the OCD loop starts to revolve around this bodily sensation. And then that feeds into the uncertainty around the medication. Should I stop this because it's potentially dangerous? Is this the right thing for me? I want certainty. The OCD screams that it wants the certainty. But here's the thing that's important to appreciate, and I think might have been dismissed by other psychiatrists that John saw. And that's that these sensations, these experiences, they weren't all in his head. The answer wasn't just telling him to stick with it or switch a medication. Because anxiety doesn't necessarily make experiences imaginary. They're very real. His suffering was very real. Yes, OCD may have been amplifying the anxiety and changing the internal narrative around the experience of that sensation, that medication. But yet the suffering, the panic, the anxiety, that was still very real for John. And that should have been addressed. There's another factor here I should mention. And that's known as the nocebo effect. It's kind of the opposite of the placebo effect. With the placebo effect, there's high expectation that a medication will do something positive. And so it tends to make people feel better, even if it's not actually doing anything, even if it's just a sugar pill. The opposite can happen as well. People can take a medication, and because they're so anxious, so worried, either just being influenced by what they read online, prior experiences with the medication, or just anxiety in general. And so then they can take the medication, and even if it's not doing anything harmful, they still experience a lot of side effects. They're not imagining or faking symptoms. They're actually experiencing true sensations, true experiences. The anxiety itself creates real physical sensations, which then, of course, increases the anxiety, which creates more sensations, and on it goes. So now going back to John's spreadsheet, there was another sort of approach to that. Because there were so many different effects, it was almost biologically impossible to have that sort of reaction to everything to such an extreme extent. And so it became less of a medication side effect history and more of an OCD history. But before we go any further, I want to make something very, very, very clear. This absolutely does not mean that medication side effects are not real. Sometimes medications generally aren't tolerated. Sometimes they have to be stopped or switched. And my job as a psychiatrist, when done well, is not to say this is 100% a side effect, 100% anxiety or OCD. It's to hear out your experience, to hear where you're coming from, and try to figure out, along with you, filling you in on my thought process about it of, is this a medication side effect? Is it OCD? Is it a combination of both? And what's a way forward that you feel comfortable with my guidance of moving forward? That's where a lot of the art in OCD treatment comes in. It involves a lot of trust building, a lot of explanation, a lot of openness between the clinician and the patient. And the danger of not doing that is every time a medication is tried and there's any sort of distress around it, it's stopped. Because if I assume every symptom is a medication side effect, I might stop a medication too early that might have greatly helped. But if I assume every symptom is just OCD, I could miss a genuine adverse reaction. And getting that balance right is not easy, but it is possible. So, what did we do after that first visit? Interestingly, not very much. At least not at first. Right away, I didn't want to start any medications. I also didn't tell John that all of his past adverse reactions were probably all OCD related. Instead, during that first appointment, I just wanted to listen. I wanted to make John feel heard. We went through many of the medications, the experiences, what it felt like for him, his frustration. John really needed to feel that someone was going to take him seriously, that someone would listen to his experiences. And he deserved that because he had really suffered and he was looking for a way forward. He was looking for help. One of the things I've learned from treating OCD over the years is that people are much more willing to sit with uncertainty, take on the challenge of treating their OCD when they feel genuinely heard and like they feel safe in someone's care. So I held back. I resisted the urge to change anything immediately and stir things up. So next time he came in, we had a little bit more time to discuss what could be going on. And I explained to him a little bit about how OCD itself can latch on to one's experience of a medication. And though he was hesitant about this interpretation, he was also open to it. He was open to trying a medication one more time at a very minuscule dose. And I said to him, John, our goal is not to prove that you will have no side effects to this medication. And he nodded. And then I said, and our goal is also not to prove that every sensation is related to OCD. Our goal is something much more difficult, but also much more helpful. And that's because OCD is always looking for 100% proof, 100% certainty. Is this a side effect? Is this OCD? Is this medication right for me? Is it wrong for me? Is it helping? Is it not? We're going to pull back from those absolutes. And he seemed a little bit uneasy at this, but he said, okay. But before I started any medication, I wanted him to start seeing a therapist that specialized in OCD, an exposure response prevention therapist that he could see weekly. And the goal with seeing this therapist was not to start working on his hierarchy of the different things that was causing him distress, the just right OCD. He was actually going to use the medication itself as the first exposure. And we started off at a tiny little dose of sertraline or Zoloft. Of course, the next day I got a long email. Again, he was distraught. He tried it that morning and within an hour he was experiencing blurry vision, incredible bloating, headaches, feeling just unlike himself, feeling out of it. And my response was intentionally vague and minimal. I thanked him for reaching out, told him that based on what he reported, nothing seemed dangerous, and I looked forward to seeing him at our regular visit 2 weeks from now. So notice what I didn't do. I didn't analyze the symptoms. I didn't try to refute or argue with any of them. I didn't even acknowledge them very much because I didn't want to provide endless reassurance, endless fodder for the OCD to latch onto. Because oftentimes when people with OCD do reach out with a lot of these concerns, it is a reassurance-seeking behavior. They want reassurance. So a clinician has to be very careful as to how they respond. But working in tandem with this therapist, we're actually able to have him sit with the uncertainty, sit with the bodily discomfort, and just take it one day at a time, one experience, one sensation at a time, and not needing to know for certain, is this a side effect? Is it not? Is it dangerous? Is it not? But refocus back on his life. And gradually, over time, John did start to get better. He started to feel less anxiety, less of his mental bandwidth was taken up by this worry around medication. And we just kept it at a very low dose. I actually doubt it was doing anything, but it allowed him to start some exposure work that was focused on this. And then that opened the door for him to do exposure work on his actual OCD symptoms that were bringing him to see me. And then we were able to slowly increase the dose. And that, along with the therapy, did see him have great reduction in his symptoms. It wasn't overnight, it wasn't over the course of weeks or even months. It was over a year of treatment that things improved over, but it did get better. His concerns about the medication eventually faded into the background. And his relationship with uncertainty, with how he experienced bodily sensations, all of that changed. So I think the biggest takeaway from this story is this. Starting new medication can feel very terrifying. I hope people don't assume that they're too sensitive to medications for treatment, but that they also don't dismiss potential adverse effects as just their anxiety or OCD, but rather that they have a skilled clinician who can walk them through the nuanced and sometimes blurry path of trying something like a new medication. And sometimes medications genuinely aren't the right fit, and therapy alone is best. But other times, the OCD tries to infiltrate whatever treatment modality is trying to reduce it, trying to tackle it. So this can be medications, and of course I've even seen OCD attach itself to therapy to try to make people question, is the therapy making me better? Is it actually making things worse? Do I really have the OCD that responds to this type of therapy? So it's not just medications that the OCD can latch onto. And if you enjoy these story-driven discussions about OCD and anxiety, please consider liking and subscribing. It really helps out. And thank you so much for watching to the end. I really appreciate you. And I hope to see you in another video next week.